My name's Lee Short. I'm a podiatrist with a heavy musculoskeletal background. I qualified in 1994. I did my master's degree in 2001 in clinical biomechanics.
My name's Bob Longworth. I've been a podiatrist since 1986. I qualified at Salford. Worked mainly in the NHS, but in the last couple of years been working in private practice.
Hello, my name's Simon O'Donnell. I'm a musculoskeletal podiatrist, though do some chiropody and have done for many years. I've qualified initially in 1985 and have worked in a wide variety of different clinical settings, both in the public and private sector.
Podiatry Clinics Yorkshire, we try to strive for excellence. We use the latest technology and make everything as evidence-based as we can. And one of the things with insoles that a lot of the literature shows is that using a casted device that's expensive and takes a long time is no better really than using an off-the-shelf device that we can adapt here. So that's the approach we take.
Running rehabilitation is a big part of our clinical practice, to the point where we've seen a number of elite triathletes. Particularly, it's been a difference between having to miss the Worlds and actually winning a medal. Running rehabilitation isn't just for elites. We do offer that service for novice runners right the way through to elites, and we can have a big input together with their coaches and be able to get them back to full fitness quicker than normal.
We specialise in MSK work, musculoskeletal work here, sometimes called orthopedics, that type of thing, where we're trying to keep people away from orthopedics really, stop them from having surgery or needing it. And we produce everything here in the clinic on the day, so if a patient comes in and needs insoles, they'll leave that day with insoles. There's no casting and long waiting like we used to do in the old days. The problem with the casted device is it takes a long time. You've got to get the patient in to do the casting. It's got to wait for it to dry. You've got to send it away to the lab. You've got to hope that the lab makes it exactly the way you want it to. It comes back in a few weeks' time, and then you finally fit it to the patient. Whereas the way we do it, it's done in clinic. If a patient needs an insole, they walk out with it on the day that they need it. It's about a quarter of the price that it would be of the other way, and it's hopefully the rehabilitation happens much quicker for the patient.
I use motion metrics with the guidance of my colleague Lee Short and also with Bob Longworth. I have to say it was very challenging initially trying to alter my running technique. After a bit of perseverance and getting really tired initially, it's achieved results. I've gone from a grade E, which basically that puts me in the category of a fridge you couldn't sell, to a grade C, a reasonable runner.
The tracking system's going to triangulate about in the middle of the treadmill here, okay, and it's going to track you quite nicely from here. If you go too far forward, it won't track you so well. So we need you to try and run roughly in the middle of the treadmill. Once you get comfortable with that, you're used to that, then we're going to start the test procedure, okay? We recommend that we're going to get people running for at least 10 minutes before we start taking anything for them, okay? So we're going to get you running for 10 minutes. This first bit here is almost like an economy sort of screen, tells us how economical your running style is, and at the moment you're sort of at the top end of what the average population would be. If we look here, this represents the vertical displacement, the amount of up and down force of your centre of mass and the vertical displacement of your centre of mass, and we can see it's very, very symmetrical here. What we'll do now is we'll send this to your iPhone immediately, so as soon as we're finished here, it'll email straight over to your iPhone, so you can look at this at your own leisure, and you can take it back to your coach, so he can see that tweaking these little performances, together with a few exercises that we're going to give you today, and some advice with your coach, what we need to be working on in the short term, and hopefully this is going to improve your performance.
One of the good things about being in private practice is we can buy in the stuff that we know works, or that we have looked at the research for. For instance, there's this Turbomed. So if somebody's got a drop foot, they're normally given an AFO that can be really uncomfortable, but this clips onto the shoe and works a treat. And we've had patients try this and be crying in the clinic because it's worked so well for them.
When we use foot orthoses, we try to consider the reason why a patient needs them, generally because they've got pain. What we try to achieve generally is getting people out of pain or the causes of their pain. This often means analysis of movement. We try to get some idea of the measure of forces which may be causing the problem, which causes the pain.
So moving from the NHS into private practice, you're in total command really, from the minute the patient comes in to then when they leave, as to the type of treatments you give. And we try to keep everything evidence-based here as much as possible, and make the patient journey as smooth as possible too.